So the topic of my presentation is psoriasis and tuberculosis in the era of new biologic therapies. And in fact, it's not uncommon for us in clinical practice to face patients with psoriasis and tuberculosis, mainly latent tuberculosis. And we have been treating these patients, but we also have been managing tuberculosis the same way in all patients, regardless of the therapy that we are using. And many of these patients develop side effects, toxicity to TB drugs. So, in fact, nowadays, with the advent of new biologic therapies, the management of tuberculosis is changing. So, my objective for today is to discuss with you the management of tuberculosis in this new era of new biologic therapy. So, my disclosure. And let's start with the clinical case. This is a 62 years male patient with severe psoriasis, no psoriatic arthritis, some comorbidities, hypertension, high cholesterol, high triglycerides. He's also hypocoagulated with warfarin due to auricular fibrillation. He's quite obese. He's taking too much alcohol, and also he has increased hepatic enzymes, probably due to the alcohol intake, but also probably due to fatty liver disease. And he was referred to our clinical department, no previous systemic or biologic therapy, and we made a diagnosis of latent tuberculosis. So the question is how to manage this patient. I think it's clear that this patient has a higher risk for toxicity for the treatment of latent tuberculosis. So should we treat this patient for latent tuberculosis? Should we not treat? How safe is to treat this patient? And also, if we decide not to treat latent tuberculosis in this patient, how should we treat this patient for his psoriasis? Okay, let's talk a little bit about tuberculosis. Well, tuberculosis remains a significant global health concern. In fact, tuberculosis ranks among the top 10 causes of mortality worldwide and is the leading cause of death by an infectious disease. So in terms of infectious disease, this is one that is killing more patients. And if you look to this map of incidence of tuberculosis, green is good, darker green is even better. So it's very low incidence of tuberculosis. And if you look at Europe, Europe is doing well, along with the North America and also Australia, comparing with South America, Africa, or Asia. But if you look at Europe, my country, Portugal, is not doing so well. It's one of the worst countries in terms of incidence in Europe. It's green, but it's a very light green. And Spain is not in the better group of patients with dark green, like Scandinavia or Central Europe. So it's something that we still have in our clinical practice to deal with tuberculosis, or at least latent tuberculosis. So what happens, and we should not forget also, we live in a global world, so we have millions of immigrants, millions of tourists traveling, coming from high incidence countries. So this may change over the years. So what happens when we contact with tuberculosis? Well, in the immune-competent host, TB infection is initially controlled by the immune system through the formation of granulomas. So the patient will have a latent tuberculosis infection. And it's estimated that around 25% of the world population have latent tuberculosis. What we also know is that 5 to 10% of these patients, immunocompetent patients, will develop active tuberculosis. So every patient has a basal risk, an inherent risk of reactivation, even being immune competent. So everyone here we all have this inherent risk of developing, of reactivating tuberculosis. Then there are some medical conditions or drugs, immune suppressive, immune modulator, that will increase this risk of reactivation. We talk about HIV, diabetes, kidney disease, cancer, and also drugs that are used, immune suppressive drugs in transplant patients, but also drugs that are used in immune-mediated diseases like psoriasis, such as TNF inhibitors. And we all know that TNF inhibitors increase the risk of TB reactivation. This is well known, it's well reported. Th1 cytokines like interferon gamma, IL-12, and TNF are very important for the granuloma formation, so for latent tuberculosis. And there's a lot of data, both from clinical trials, from real-world studies showing the increased risk of latent TB reactivation in patients treated with TNF inhibitors, particularly in the first month of treatment. For example, the first infliximab trial showed an increase, 4-time increase of the risk of TB infection. So there is no doubt that TNF increased the risk of reactivation. That's why the guidelines that we have for the management of patients with psoriasis recommend that we should screen all patients that are starting biologic therapy, regardless of the agent that we are going to use to treat our patient. And also very important is that if latent TB is detected, all patients should be treated for the latent tuberculosis before starting the biologic therapy, regardless of the chosen agent. So we should screen all patients and we should treat all patients. But sometimes we have patients like this one, and there's an important risk of toxicity if you want to treat latent tuberculosis. There's a risk of hepatic toxicity to isoniazid, as we're going to see, the risk factors for that, and also the risk of drug interactions between warfarin and rifampicin. So in this patient, we decided not to treat latent tuberculosis because the risk was too high. And in fact, there are many patients like this one that I described that cannot or should not be treated for latent tuberculosis because they have factors that are associated with a higher risk of side effects or toxicity to TB drugs. We're talking about advanced age, like our patient, pre-existing liver disease, hepatitis B or hepatitis C, other liver disease risk factors like alcoholism, like in this patient, diabetes, being overweight or obesity, like in this patient, or taking other drugs that may be or are hepatotoxic. Also, malnutrition, HIV, chronic renal disease also increase the risk of toxicity to some of these drugs. Thrombocytopenia may be aggravated by rifampicin, pregnancy, of course, and also we should not forget all the drug interactions that rifampicin may have. So patients with latent tuberculosis with some of these factors are at higher risk of toxicity or complications of chemoprophylaxis. So this preventive strategy may need to be waived. And the question is, but can we still treat this patient for the psoriasis? So he has a high risk. We don't want to treat the patient for latent tuberculosis, but we need to treat psoriasis. Can we still treat these patients? How can we treat these patients? Do all psoriasis treatments increase the risk of TB reactivation? We recently reviewed this topic, and what we know is that methotrexate and acetylcholine have a low risk or no risk of reactivation, but I will not use in this patient because of risk of hepatotoxicity. Cyclosporine increases the risk, but it's not probable to see this risk of reactivation in psoriasis patients because the dose is lower than what we see in transplant patients. And also, usually we don't use concomitant immunosuppressive drugs, so it's not expected to see this risk in psoriasis patients. And then apremilast. I don't have experience with apremilast. We don't have apremilast in our country, but it seems to be safe. The data that exists show that probably there is no risk of reactivation with apremilast. There's a lot of data from clinical trials, but the idea that I have is that it's not very effective. So probably would not be very effective in this patient. So for these drugs, there is no need to treat latent tuberculosis when using these drugs, conventional systemic therapy and apremilast. Well, for TNF, we already know it decreases the risk. For ustekinumab, well, IL-12 is important in the granuloma formation, so potentially blocking IL-12 may increase the risk of TB reactivation. There is real-world cases of infection and reactivation in patients receiving ustekinumab without chemoprophylaxis. So in these patients, as we all do, chemoprophylaxis is important, is recommended, and is effective, reducing the risk of reactivation. When using these drugs, chemoprophylaxis is recommended. How about IL-23 and IL-17 inhibitors? Well, preclinical data, animal data, clinical data shows that probably IL-23 and IL-17 do not increase the risk of reactivation. Data from preclinical studies and mouse models show that the absence of IL-23 or the shortage of IL-17 do not change the progression of the disease as long as Th1 response is not compromised. And we know that IL-23 and IL-17 inhibitors do not compromise Th1 response. And another nice study using a human microgranuloma model of tuberculosis evaluated the effect of the adalimumab and secukinumab on the reactivation of this model, and as expected, adalimumab showed to increase the risk of reactivation, while secukinumab did not show to increase the risk of reactivation. What data do we have from randomized clinical trials? We have some data of the risk of tuberculosis reactivation in patients with non-treated latent tuberculosis who were treated with IL-17s and IL-23. We have data with risankizumab, also with ixekizumab, and no cases of reactivation. And the same thing is being seen in real-world studies without case of reactivation in patients with non-treated latent tuberculosis who were treated with IL-17 and IL-23. We see some case reports, some small case series, well, nevertheless showing no increased risk of reactivation. And now I just wanted to present some data from a study we just published with a large number of patients, psoriasis patients with latent TB, non-treated latent TB, treated with IL-17 and IL-23 inhibitors. This was a retrospective, multinational, multi-center study for centers from Portugal, Spain, Italy, Greece, and Brazil. José Manuel participated, Luis Puig also participated, and with a large number of patients. We're talking about 405 psoriasis patients with newly diagnosed of latent TB that were treated with IL-17 and IL-23. And we see that almost 40% of the patients were not treated for latent TB or received incomplete treatment of latent TB, so mainly due to the risk of hepatotoxicity or development of any toxicity to these TB drugs. And what we observed was that for a mean follow-up of 33 months, there was only one case of reactivation of active tuberculosis, a case of active intestinal tuberculosis after 14 months of therapy with ixekizumab. And this percentage is within the expected rate of reactivation, 5 to 10%. So the basal risk of any patient. And of course we can discuss, well, but it's extrapulmonary tuberculosis. Well, it's true, but this has also been reported in immune-competent subjects. And another important point is that this reactivation occurred a little bit too late, 14 months after the starting therapy with ixekizumab. And usually the reactivation that is associated with drugs, with immune-suppressive drugs, is commonly observed within the initial 6 months. So probably this reactivation may be only associated or due to the basal risk of any patient that can have reactivation because they have latent tuberculosis. So the conclusions from this study is that risk of tuberculosis reactivations in patients with psoriasis does not seem to be increased with the use of IL-17 and IL-23 inhibitors, of course, so we should prefer these agents over TNF inhibitors when we have concerns about tuberculosis. And of course, in those patients with latent tuberculosis, with high risk of toxicities to TB drugs, maybe it's better to waive this preventive strategy and treat these patients with IL-17 and IL-23 inhibitors. So coming back to our patient, this patient was treated with IL-23 inhibitor for 1.5 years, is well controlled, no side effects, and no TB reactivation. So some take-home messages. So facing psoriatic patients with latent TB is not uncommon. Anti-tuberculosis therapy is associated with several side effects, so the risks and benefits of treating latent tuberculosis should always be balanced before making any clinical decision. The current data we have is reassuring regarding the use of IL-17 and IL-23 in these patients with latent tuberculosis, with no evidence of increasing the risk of reactivation, even in those patients with untreated latent tuberculosis. Of course, we should use these agents preferred over TNF antagonists, and we can waive the treatment of latent tuberculosis in some patients. Of course, we think, and probably it's better, screening can still be performed in order to assess the global health of the patient, but this is very important. The diagnosis of latent TB should not dictate his treatment especially in patients with high risk for chemoprophylaxis, and also probably current guidelines for the management of latent tuberculosis in these patients maybe it should be discussed and reviewed, because probably there are some patients that we should be waiving the treatment of latent tuberculosis. Thank you so much.
Thank you, Tiago, for this very, very practical talk. Is there any question from the audience? Okay, I would say that which is the position or the statement of your guidelines or the Portuguese guidelines, because we, in our recent update of our recommendations, we really position in this way. So telling that really if we had a patient in this really patient like that you presented, we should choose probably this kind of biologic therapy. Do you have done this way too?
Well, the guidelines in our Portuguese guidelines for treatment of psoriasis, we don't go in detail, but we don't have this kind of wording, and I think we should change. We have some guidelines from our colleagues from infectious disease, from a joint group, but some years ago we didn't have yet these new drugs. So at least in Portugal, we don't have this kind of guidelines with this wording. That I think it's important to have guidelines supporting our action, because a lot of us are doing this in clinical practice, but usually those that are experienced treating these patients. But there are a lot of colleagues that treat patients with psoriasis, severe psoriasis, with biologics, and because they are not so experienced, they may be afraid of not doing the treatment of latent tuberculosis. So I still think this is an important topic that should be stressed in many guidelines.
Okay, your article indeed, so might help in this topic. So with the evidence
yes, because we also needed some strong evidence. Of course, we if we look at and that table that I put with real world evidence, there are not so many patients. There's an important study from Spain with 35 patients, but then there's 2, 3, or 10. So I think it was important to have this kind of evidence to clear strong this point in the guidelines, and I think that in the future the guidelines will be changed. Yeah.
Okay. Thank you.